Bismillahirrahmanirrahim. Quote of the day: the key to success is to focus on goals, not obstacles. Assalamu alaikum. Today, the topic of my presentation is typhoid, which is also known as enteric fever. It is one of communicable disease. Learning outline of my presentation is first we present a case, then epidemiological factors, chain of transmission, clinical manifestation related to typhoid fever, level of prevention, and recent advances. At the end of this presentation, participants will be able to describe the epidemiological aspects of typhoid, preventive aspects of typhoid, national and global updates, and recent advances at the end. First, we present a case. 7-year-old girl presented with 7 days of fever up to 40 degrees, 3 days of non-bloody diarrhea, and 1 episode of vomiting. Abdominal pain began on the day of presentation. She had no other infectious symptoms. Her examination was remarkable only for her fever. Her parents gave history of traveling from Karachi to Lahore by train 10 days back. Investigation included a complete blood picture in which leukocytes 5.6, lymphocytes 2.65, and eosinophils 0.8%. Hemoglobin level is 107 gram per deciliter and platelets 205. Alanine aminotransferase level is 56 and an aspartate aminotransferase level is 80. Urine analysis revealed pyuria but no bacteria, red cells or nitrites. Her chest x-ray was normal. 3 malarial smears were negative. Blood culture grew gram-negative bacilli identified as Salmonella typhi. The differential diagnosis include in the top of the list there is the suspicion of typhoid fever, malaria, hepatitis A, and the dengue fever, and the most likely diagnosis is typhoid fever. Now we discuss the factors of typhoid fever one by one. Sign and symptom of typhoid fever is constipation or diarrhea, headache, nausea, abdominal pain or discomfort, relative bradycardia, rash of flat rose-colored spot, high-grade continuous fever. Introduction. Typhoid and paratyphoid fever are commonly grouped together under the collective term enteric fever. Typhoid fever is caused by Salmonella enterica. Serotype typhi, and paratyphoid fever is caused by either Salmonella paratyphi, strain A, B, or C. Both Salmonella typhi and Salmonella paratyphi cause a fecal oral transmitted systemic disease. However, Salmonella paratyphi causes a less severe illness. What is the problem statement of typhoid fever worldwide? WHO estimates the global typhoid fever disease burden at 11 to 20 million cases annually, resulting in about 128 to 161 million deaths per year. Typhoid fever is endemic in Asia, Africa, Latin America, Caribbean, Oceania, but 80% of cases came from Bangladesh, China, India, Indonesia, Nepal, Pakistan, or Vietnam. Typhoid risk is higher in population that lack access to safe water and adequate sanitation. Poor communities and vulnerable groups, including children, are at highest risk. This is the global picture of typhoid fever, the prevalence of typhoid fever in which countries are more, are highlighted as red in color. Report some outbreaks from the Pakistan. Report by the National Institute of Health, Islamabad, a total 14,360 extensive drug resistance has been reported in Karachi from January 2000 till June 2021, and from November 2016 to June 2021, a total of 5,741 confirmed cases of extensive drug resistance typhoid fever were reported in all districts of Sindh province, while 69.5 cases were reported from district Hyderabad. In 2019, Pakistan became the first country in the world to introduce the WHO recommended typhoid conjugate vaccine into its routine immunization program. Multi-drug resistance typhoid. In multi-drug resistance, there is a resistance to three antibiotics: ampicillin, trimethoprim, sulfamethoxazole, and chloramphenicol. And in extensive drug resistance typhoid, there is a resistance to five antibiotics: chloramphenicol, ampicillin, cotrimoxazole, fluoroquinolines, and third-generation cephalosporins. Only three antimicrobial drugs, namely azithromycin, carbapenems, and tetracycline, are effective against the extensive drug resistance strain of typhoid. During the current pandemic, poor sanitation is causing a surge in typhoid, and the existing outdated diagnostic methods are paving the way forward irrational pharmacotherapy. Particularly, research has highlighted the overuse of azithromycin to treat COVID-19, and this practice might impair one of the few remaining solutions against the extensive drug resistance, Salmonella typhi. Facing COVID-19 and extensive drug resistance simultaneously can result in a catastrophe in Pakistan because it is entirely occupied with the pandemic. There are three types of epidemiological determinant: agent, environment, and host. Agent. Salmonella typhi is the major cause of enteric fever. Salmonella para and S. para B are relatively infrequent. Salmonella typhi has three main antigens, O, H, and VI. The factor which influence the onset of typhoid fever in man are the infecting dose and the virulence of the organism. The genus Salmonella belongs to Enterobacteriaceae. It is facultative anaerobe gram-negative bacilli distinguished from other bacteria by biochemical and antigen structure. Post age. Typhoid fever may occur at any age. Highest incidence of this disease occur in the 5 to 19 years of age group. More cases are reported among males than females, probably as a result of increased exposure to infection. All ages are susceptible to infection. Antibody may be stimulated by the infection or by the immunization. Among the host factors that contribute to resistance to Salmonella typhi are gastric acidity and local intestinal immunity. And the environment that are responsible for typhoid fever. Enteric fever are observed all through the year. The peak incidence is reported during July to September. Outside the human body, the bacilli are found in water, ice, food, milk, and soil for varying periods of time. Typhoid bacilli do not multiply in waters. Many of them perish within 48 hours, but some may survive for about 7 days. Vegetables grown in sewage farms or washed in a contaminated water are positive health hazard. Incubation period usually 10 to 14 days, but it may be as short as 3 days or if 3 weeks, depend upon the dose of the bacilli ingested. Mode of transmission is fecal oral route, ingestion of contaminated food, water, and milk. And there is a 5 F's which are responsible for the mode of transmission: flies, finger, feces, food, and fornication. Source of infection. The primary source of infection are feces and urine of cases or carrier. Secondary source may be contaminated water, food, finger, and flies. There is no evidence that typhoid bacilli are excreted in sputum or milk. The cases and carrier are the reservoir of this infection. There are some definition of typhoid which are used in the surveillance. Probable and suspected case of typhoid fever: a patient with documented fever for at least 5 days, prior to presentation with rising trend in clinic and having no other focus to explain the cause of the fever, or clinically compatible case, that is epidemiological link to a confirmed case of typhoid fever. And how we can define the confirmed case of typhoid fever? A patient with persistent fever lasting 3 or more days and Salmonella typhi isolated on blood or a bone marrow culture. And the definition of chronic carrier: an individual excreting Salmonella typhi in the stool or urine for longer than 1 year after a blood culture confirmed episode of typhoid fever. In the absence of a culture confirmation of prior illness, it is not possible to label a person as a carrier. There are two types of carrier: temporary carriers or a chronic carrier. Presumptive carrier and the chronic carrier are further divided into three types. Presumptive carrier: evidence of shedding of Salmonella, positive stool culture or PCR of an unknown duration. And the definitive carrier: evidence of shedding of Salmonella at least 12 months after finishing an appropriate course of antimicrobial treatment and the resolution of symptoms following a laboratory confirmed episode of acute disease, or two positive stools sampled 12 months apart. Convalescent carrier: they shed typhoid bacilli for 3 or more months after onset of acute illness. Salmonella cephalopeticus: positive stool culture or PCR 1 to 12 months after finishing an appropriate course of antimicrobial treatment and the resolution of symptoms following a laboratory confirmed episode of acute disease. Sorry. Reservoir of infection: human is the only reservoir. A case is infectious as long as bacilli appear in the stool or urine. Case may be mixed, mild or severe. Carriers: temporary carrier may be temporary, incubatory, excrete bacilli for 6 to 8 weeks, or carrier may be chronic, excrete bacilli for more than a year. And the classic example is Mary Millen, which is also known as Typhoid Mary, which spread the disease for many years. And Mary Millen is a food handler. She is a food handler. She was a food handler and spread the disease for many years and labeled as a chronic carrier. Now comes the prevention. In primary prevention, we can do health promotion or a specific protection. And the health promotion is done by the hygiene promotion: hand washing, avoid food and beverages from street vendor, control of flies, ensure cooked food is covered to protect from flies, avoid meat which is undercooked, choose hot foods, eat foods that have been thoroughly cooked, improvement of water safety and use of safe water for all purpose, better sanitation infrastructure, ensuring adequate and timely access to patient care. And in specific protection, there is the including vaccination, and there are three types of vaccine. In 2018, WHO recommended the first pre-qualified typhoid conjugate vaccine for intramuscular administration of a single dose in children more than 6 months of age and in adults more than 45 years of age. The uh, uncapsulated VI polysaccharide vaccine is recommended for intramuscular or subcutaneous administration in individuals more than 2 years of age, and a typhoid 21A strain vaccine is available in taric-coated capsule recommended for oral administration on alternate days in a 3-dose regime in a person above 6 years of age. Repeat vaccination is recommended for uncapsulated polysaccharide vaccine every 3 years and typhoid 21A every 3 to 7 years in most endemic settings, or every 1 to 7 years for travelers from non-endemic to endemic areas depending upon the national policies. The typhoid 2-1A vaccine orally, this vaccine is orally administered. It is live attenuated strain of Salmonella used in the and it is used in the individual more than 5 years of age. The vaccine is administered on 1, 3, and 5th day, and with the 3-dose regime, protective immunity is achieved 7 days after the last dose. The recommendation is to repeat this series every 3 years. The recommended storage temperature is +2 degrees centigrade to +8 degrees centigrade because this vaccine is live attenuated vaccine. The unconjugated VI polysaccharide vaccine, it is purified capsular polysaccharide vaccine is licensed for individual more than 2 years of age. Only one dose is required and the vaccine confers protection 7 days after injection, and to maintain protection, vaccination is recommended every 3 years. And the typhoid conjugate vaccine is a vaccine containing polysaccharide of Salmonella typhi conjugate to tetanus toxoid. Typhoid conjugate vaccine, it is given for intramuscular administration of a single dose in a children more than 6 months of age and then in adults up to 45 years of age. In Pakistan, vaccine against typhoid are currently available in Pakistan. Vivotef is a live attenuated vaccine for oral administration only. The enteric coated salmon white capsule are then packaged in 4 capsule blisters for distribution. A single dose of injectable encapsulated polysaccharide vaccine for children more than 2 years of age. Revaccination is needed every 3 years. And a single dose typhoid conjugate vaccine is approved for use in children more than 6 months of age, offer protection for at least 3 years, children and in fact over 6 months of age. And revaccination schedule is under study. Neither vaccine is 100% effective and would require repeat immunization. Vaccinate everyone, including all household members of a confirmed case, all healthcare workers, and all food handlers. And in secondary prevention, there is early diagnosis and prompt treatment. And the typhoid fever is distributed in 4 weeks, and in the first week, there is a sign and symptom of malaise, headache, cough, sore throat. The disease classically presents with step-ladder fashion, rise in temperature over 4 to 5 days, accompanied by headache, abdominal pain, constipation, and in second week, between 7 to 10 days of illness. Mild hepatomegaly, splenomegaly occurs in majority of patients. Relative bradycardia and Ross spot may be seen, and in the third week, the patient will appear in the typhoid state, which is a state of prolonged apathy, toxemia, delirium, disorientation, or coma. Diarrhea will then become apparent if left untreated. By this time, there is a high risk of intestinal hemorrhage or perforation. And the complication of this disease is hepatitis, pneumonia, thrombophlebitis, myocarditis, cholecystitis, nephritis, osteomyelitis, and psychosis. And 2 to 5% of patients may become a gallbladder carrier. Diagnostic test. Blood culture is the gold standard test for the diagnosis of typhoid and must be sent before starting antibiotic. The culture of typhi can be done from blood, bone marrow, urine, raw spot biopsy extract, duodenal aspirates, and stool. Empirical treatment for typhoid should not be commenced without obtaining blood culture. Blood culture can be taken even if patient is currently asymptomatic. A negative culture does not exclude typhoid and may warrant a repeated blood culture if the fever is not responding in 7 to 9 days of commencing treatment. Serological tests Vidal and Typhidot are not recommended in the diagnosis of typhoid because both have low sensitivity and specificity and do not provide information on antimicrobial sensitivity. Come the treatment of typhoid. Typhoid fever is a extensively drug-resistant Salmonella type. Management has become a challenge. cases, the fluoroquinolones are widely regarded as the drug of choice for the treatment of typhoid fever. They are relatively inexpensive, well tolerated, and more rapidly and reliable effective than the former first-line drug, which is chloramphenicol, ampicillin, amoxicillin, and trimethoprim sulfamethoxazole. These are the antibiotics which are used in the treatment of typhoid fever. First line antibiotic, chloramphenicol, trimethoprim, sulfamethoxazole, ampicillin, and in second line antibiotic there is ceftriaxone, cefixime, ciprofloxacin, and in third line antibiotics there is azithromycin, meropenem, imipenem, and ertapenem. The carriers should be given an intensive course of ampicillin or amoxicillin together with probenecid for 6 weeks. Eradication of the carrier state in about 70% of carrier. The carrier should be kept under surveillance. They should be prevented from handling food, milk, or water for others. There are some definition of carrier. Non-resistant typhoid fever. Typhoid fever caused by Salmonella typhi and Salmonella paratyphi A, B, C strain, which are sensitive to first-line drug and third-generation cephalosporin, with or without resistance to second-line drug, and multi-drug resistant typhoid fever caused by Salmonella typhi or Salmonella paratyphi, which are resistant to first-line drugs, sensitive to third-generation cephalosporin, with or without resistance to second-line drug. Extensive drug resistance typhoid fever caused by Salmonella typhi strain, which are resistant to all the recommended antibiotics for typhoid fever. And extended spectrum beta lactamase positive typhoid fever caused by Salmonella typhi strain, which are resistant to third generation cephalosporin, but may be sensitive to chloramphenicol, chlorotrimazole, or fluoroquinolones. Now it's time for the recent advances. This is one of the articles in which they emphasize the supply and delivery of vaccine for global health. Vaccines are one of the most successful and cost-effective disease prevention strategy ever implemented. One of the biggest challenges in global health has been securing access to these technologies for people in greatest need. Projections suggest that barely more than half of the world's children will be fully immunized by 2030. To extend the beneficial impact of vaccine and vaccination on global health, new vaccine for additional disease as well as improved supply and delivery mechanism need to be developed, particularly in low income and middle income countries. While considerable attention has been given to new vaccine for emerging or re-emerging disease by developing a proactive approach and novel mechanisms such as coalition, epidemic preparedness innovation, other poverty-related diseases, or neglected tropical diseases vaccine have raised much less attention. This is another article in which they give the information about typhoid conjugate vaccine advancing the research and public health agenda. A typhoid vaccine acceleration consortium showed typhoid conjugate vaccine to be safe, immunogenic, and efficacious at preventing blood culture, confirmed typhoid fever in African and Asian children. Pakistan, Liberia, and Zimbabwe recently induced typhoid conjugate vaccine through campaign and routine childhood immunization, providing protection from this vulnerable population. A multidisciplinary approach, including surveillance, water sanitation, and hygiene investment, large-scale typhoid conjugate vaccine introduction is needed to decrease the burden and mortality of typhoid fever. The National Antimicrobial Resistance Monitoring System for enteric bacteria was established in 1996. National Antimicrobial Resistance Monitoring System is a collaboration among state and local public health department, CDC, the US Food and Drug Administration, and the US Department of Agriculture. This national public health surveillance system track changes in the antimicrobial susceptibility of certain enteric bacteria found in ill people, retails, meat, and food animals in the United States. The National Antimicrobial Resistance Monitoring System program at CDC help protect public health by providing information about emerging bacterial resistance, the way in which resistance is spread, and how resistance infection differ from susceptible infection. Now, Pakistan is the first country to introduce new typhoid vaccine into routine immunization program. Into November 2019, Pakistan became the first country to introduce typhoid conjugate vaccine into its routine vaccination program. Now it's time for the MCQ. A massive typhoid vaccination campaign is underway in Pakistan using which type of typhoid vaccine to protect kids age more than 9 months to 15 years. Typhoid 21A vaccine, VI polysaccharide vaccine, typhoid conjugate vaccine, or a typhoid toxide.
Typhoid conjugate.
C, typhoid conjugate vaccine is right answer. Research has highlighted the overuse of azithromycin to treat COVID-19, and this practice might impair one of the few remaining solutions against which type of drug resistance? Multi-drug resistance, extensive drug resistance, methicillin drug resistance, penicillin drug resistance.
A.
B, extensive drug resistance is correct answer. Worldwide, drug resistance against Salmonella typhi is quite difficult to treat. What do you understand by the term extensively drug resistance typhoid? Salmonella typhi sensitive to first line antibiotic and third generation cephalosporin. Salmonella typhi strain resistance to first line antibiotic with or without second line antibiotic. Salmonella typhi resistance to all type of recommended antibiotic except 3, and S typhi resistance to third generation cephalosporin only.
C.
C is the right answer. There are multiple case definitions which describe the carrier state of a typhoid fever. Which laboratory test confirm the chronic carrier state of typhoid fever? Blood culture, stool culture, urine culture, or Widal test?
B.
B, stool culture. According to recent guidelines, blood culture is gold standard for the diagnosis of fever. Why Widal test is no more recommended for gold standard? Because of low sensitivity and low specificity, low sensitivity and high specificity, high sensitivity and low specificity, high sensitivity and high specificity.
A.
A is the right answer, low sensitivity and low specificity. An unsanitary borehole latrine with loads of fly is present within 10 feet of a well in a village. The disease more likely to be transmitted through drinking the water of well. Leishmaniasis, trachoma, typhoid, or dental caries.
Typhoid.
Yeah, C, typhoid is the right answer. Drug of choice for the treatment of chronic carrier state in typhoid fever is neomycin, levofloxacin, ampicillin, or probenecid. C is the right answer, ampicillin or probenecid. There are multiple signs and symptoms of typhoid fever which presented by patient in OPD and emergency setting. From these symptoms, relative bradycardia and raw spot are most likely seen in which week? First week of infection, second week of infection, third week of infection, fourth week of infection. B, second week of infection is right option. After 13 hours of eating at wedding, 15% reported abrupt onset of chills, fever, nausea, vomiting, and profuse white watery diarrhea. The most likely organism responsible for this food poisoning would be Salmonella, Staphylococcus, Clostridium botulinum, Clostridium perfringens.
A.
A. Salmonella is right answer. There are multiple vaccines for typhoid fever which are recommended for different age group. One of the vaccine is live attenuated typhoid 21A, which is the recommended temperature for this vaccine. -2 to -8 degrees centigrade, +2 to +8 degrees centigrade, -20 to 25 degrees centigrade, or 8 to 20 degrees centigrade.
A.
B is the right answer, +2 to 8 degrees centigrade. This is the key of my MCQs, and thank you.